Good afternoon, ladies and gentlemen. I am Dr. Subhranshu Sekharkar, today's webinar moderator. I am currently working as the Professor of Pediatrics and Associate Dean Clinical Sciences in RAC College of Medical Sciences. On behalf of the Honorable President, Dr. S. Gurmadhava Rao, and our esteemed Dean, Dr. L.K. Berry, I welcome you all to today's session of the very informative and up-to-date COVID-19 series of webinars. As you all know, we are conducting our series of live webinars dedicated to this pandemic situation, focusing on the epidemiology, pathophysiology, and management with special emphasis on preventive and response measures. The evolution has remained as an enigma till now, and every day new evidence are emerging about COVID-19. In this aspect, a very important saying by Dr. Michael Ryan, who is the Executive Director, WHO Health Emergencies Program, is worth mentioning. He said on a press briefing on March 13th that if you need to be right before you move, you will never win. Perfection is the enemy of good when it comes to emergency management. Speed trumps perfection. And rightly so, we cannot be complacent. To give you all an update of what is happening today, globally more than 19.5 million people have been affected, and almost 724,000 lives have been lost. In UAE, as of today, more than 62,300 people have been affected, with 356 unfortunate deaths. Last week, we had 3 very interesting talks on diagnostic and pharmacotherapeutic aspects of COVID-19. In continuation, today we'll be focusing on COVID-19 in pregnancy, pediatric COVID-19 and update, and the effect of a pandemic on mental health. Also, there will be a very interesting update by Professor Abdul Wasit Isawi on his personal experience in a COVID triaged tertiary care hospital. That will be a true icing on the cake. Before I invite the first speaker, let me clarify some webinar housekeeping issues. The question and answer session will be conducted only at the end of all the 3 presentations. So you are requested to put your doubts in the question section only. The certificate of attendance will be sent to you via your registered email. You are requested to fill up the questionnaire survey, which will be emailed to you. We would love to hear from you in case you have got any further queries. So you can mail us at events@racmhsu.ac.ae for further clarification. A recorded version of this webinar, along with the presentation, will also be made available in our website as well as YouTube channel for your reference. Now, I would like to introduce today's first panelist, Dr. Rajni Dubey. Dr. Rajni Dubey is currently working as Professor of Obstetrics and Gynecology at RAC College of Medical Sciences and as a specialist gynecologist at RAC Hospital. She received her basic MBBS degree from SCB Medical College, Cuttack, India in 2000 and MD in Obstetrics and Gynecology through All India PG entrance from SCB Medical College, Cuttack in 2004. She received her PG diploma in Artificial Reproductive Technique and Reproductive Medicine from the University of Schleswig-Holstein-Kiel, Germany, and certificate in prenatal care from Michigan University, USA. In addition, she has also had advanced laparoscopic surgery training and training in ultrasonography in OBG from Fogsy, India. She has more than 25 research publications in reputed national and international journals and couple of book chapters to her credit. She will be talking on COVID-19 in pregnancy. Please go ahead, Dr. Rajni.
Thank you, Dr. Kar, for the nice and kind introduction. COVID-19 has changed us forever. So naturally, it has impacted the care in the pregnant women and newborn. I have no conflict of interest, neither any disclosures to make. Today, I'll walk you through
Your slides are not moving.
Yeah, now it's okay?
Yeah.
Yeah, today I'll walk you through effect of disease on pregnancy, effect of pregnancy on the disease, changes in management due to this pandemic, and we'll end it with role of pregnant women during this pandemic to make pregnancy and childbirth safer. Okay, so as you all know, novel coronavirus, also called SARS-CoV-2, is a new strain of COVID coronavirus. The infection is known to us recently, and the pandemic is rapidly evolving. For those factors, there is currently a lack of high quality evidence, which is affecting our management protocols now, which is updated regularly. So at any point of time, the management is based on the evidence available. Now, what are our concerns for COVID in pregnancy? Now, since fetus is a foreign body, or it's a new human being growing inside mother, it has to make changes to adapt to that growth of the baby. So it alters the body's immune system. Now, due to that, there can be some alteration in the immune response to other viral infections, including COVID-19. Now, from our experience, we know that some viral infections like influenza or SARS-CoV or MERS-CoV, the last two are COVID coronaviruses, are worst in pregnant women. To that effect, it can lead to renal failure and death. Now, pregnant women are considered as clinically vulnerable or at moderate risk because of her experiences with the other viruses and because of the physiological changes during pregnancy. Now, in addition to that, there may be effect of pandemic itself, like there can be escalation of pre-existing issues like stress, anxiety, depression, and domestic violence. So since WHO has said that whatever the situation may be, we have to make the pregnancy, childbirth, and the mental health as safe as possible. So now, what are the effect of pregnancy on the disease? So how is the disease different in a pregnant woman? Now, the overall risk to pregnant women is still very low. The symptoms of severe infection that we see in general population, like the shortness of breath or fever, even loss of consciousness, all these are similar in pregnant women, and pregnancy-related changes that can lead to severe symptoms, specifically in the last 3 months of pregnancy. Now, there is increased risk of ICU admissions and mechanical ventilation, but there is no increase in rate of mortality. Now, these are the high-risk factors for pregnant women. If they have it, the disease can be more severe. Now, certain ethnicity like African or even Asians, they have increased risk for getting admitted when they have COVID infection. When they are obese, the chance for having the infection does not increase, but when they have the infection, they are more likely to get admitted with severe disease. Like we all know, pre-existing comorbidities like diabetes and hypertension can lead to severe infections. And if the maternal age is more than 35 years, it can lead to admissions more often. Now, what are the concerns of the effect of disease on pregnancy? We are all worried about the transmission of the fetus. If so, what will be the fetal effects? What are the overall effects on pregnancy? And there can be effect of challenges to access healthcare. Now, there was an interesting study in England on this. They found that the stillbirth rate in women is increased during this pandemic. Now, these women were not infected with SARS-CoV-2. They were low-risk women. Now, this is alarming. They did not go to their antenatal follow-ups for the fear of getting infected. So that is the alarm here. One, there can be effect due to COVID infection. Second, due to the fear of getting infected, they might not have antenatal care. Now, coming to effect of disease on pregnancy, the current data do not suggest any risk of miscarriage, neither fetal growth restriction. but we all monitor the fetus for fetal growth restriction if the woman is admitted with severe disease, because fetal growth restriction has been seen with infection with other coronaviruses. There is an increased risk of preterm birth, which is the delivery before more than 3 weeks of your expected date of delivery. Now, apart from all these, simply having high fever during first trimester can increase certain birth defects like cardiac defects and neural tube defects. So this has to be considered as well. Now coming to in utero transfer. In utero transfer means when the mother is having COVID infection, can the baby be infected when it is still inside? The data here is conflicting. So one thing to consider here is, normally in infections, we see whether the virus is positive in the amniotic fluid. So there are studies which found the virus in amniotic fluid, but the fetus itself do not have enough receptors for this virus to get inside the body, like ACE2 receptor and TMPSS. So it is very unlikely that the virus will go to the fetus when it is the fetus is still inside the body. However, there is chance for transmission while delivering, or most often it is after delivery. So postnatal transmissions are much more than intranatal transmissions. Coming to management. Okay, now management aims at stabilizing her condition first by standard supportive care, which is done by a multidisciplinary team, which has a physician, if possible, an infectious disease specialist, with an obstetrician and anesthetist after active discussion with the patient. Patient is involved in this process, and as we all know, there is no approved therapy for COVID-19 so far, but cases are managed according to the local protocols, according to the status, whether it is a suspected case or confirmed, with or without pneumonia, and the severity of infection. What is different in pregnancy is this favipiravir and ribavirin are absolutely contraindicated in pregnancy due to its high toxicity in the fetus. Plus, in pregnancy, nebulized interferon alpha and beta 1b can be an option in addition to other treatment. Now, during pregnancy, as it is the prothrombotic state, we also use thromboprophylaxis, and steroid is used for severe infections. Now, what are the changes we have brought in our antenatal care during this pandemic? We have used teleconferencing and video conferencing wherever possible. We have reduced the antenatal visit to 6 visits for low-risk pregnancy, but for high-risk pregnancies, as often as required, you may have to attend. The care is unchanged for the patients who have recovered with mild, moderate symptoms, those who did not need a hospitalization. Now we are trying to limit the repeated clinic attendance by combining a face-to-face examination with investigations like a blood investigation or ultrasound in the same sitting, so that she doesn't have to come back again. When the patient is seriously or critically ill, their fetal growth scans are required. Thromboprophylaxis is given for all admitted patients with confirmed or suspected, unless the delivery is imminent, and steroid therapy is given for whoever requires oxygen therapy. Now, during pregnancy, we do not use dexamethasone, as it can go to the fetus. So we would rather use prednisolone or IV hydrocortisone. Now, what are the changes we have seen for labor and childbirth? Now, in some of the countries, they have temporarily put on hold the option for birth at home. Okay, now induction of labor should be reconsidered, because induction of labor needs prolonged hospital stay as compared to patients who are admitted while in labor. Now, donning the PPE for emergency cesarean is time consuming, but it is essential for us, and this may impact the time to delivery, and this we have to consider. And the persons which we allow for delivery or to support the laboring woman is either avoided or restricted to one person. Now, what are the changes in management? If the woman is symptomatic or confirmed, it is mandatory that they give birth in obstetric unit, not any other place. Positive tests per se do not warrant early delivery if the mother and the fetus are okay. Mode of delivery is again not influenced by the presence of COVID only. Now, some of the studies says that the chance for cesarean delivery is more in COVID patients, but those are due to the complications seen in the mother. And we have, though the virus is present in vaginal fluid, is very unlikely that if you do a cesarean section, infection to the fetus can be prevented. Now, birthing pools or water bath delivery is avoided because it has been seen that the virus is present in the fecal matter, so it might go into the baby. And all these decisions about induction or augmentation, whether to use instrument during delivery or whether we are preferring a cesarean section, it is individualized and it is decided with thorough discussion with the patient herself and policies. Now, what is the problem or what is the management in postnatal period? Now, if the patient needs admission, then it will be she will be admitted into the isolation ward and it will be managed by a multidisciplinary team. If she does not need admission, then she can be shifted to a normal postnatal ward with isolation from other patients who are not infected. Now, coming to all postnatal care in general, all women with COVID-19, they will receive thromboprophylaxis because as such pregnancy is a prothrombotic state and COVID-19 infection also increases chance for thrombosis. Now, care is individualized, which takes into account the clinical condition of the mother and the neonate, availability of testing and staffing with space and PPE in the facility. The result of neonatal testing, when you test the neonate, if the neonate is already positive, there is no point in separating the mother and the neonate. And the pregnant individual's home situation, when she is discharged to home, whether it is okay for her to be there. Now, pregnancy with COVID-19 is not a contraindication to breastfeeding. So if she is okay, she is doing well, so she can breastfeed her baby. Babies need not wear masks because there is chance for suffocation. But the pregnant woman as such has to maintain the hygiene. She has to put a mask, do hand washing, and all the precautions to avoid infection to the baby. The household also needs to isolate for 14 days after delivery. Now, temporary separation is sometimes required for these patients because of the maternal and fetal condition. So if she is too unwell to feed, she will have to express her milk, and that will be feeding will be done by some other personnel. Now, what is the role of pregnant women in all this? Now, if you are not infected or you don't have any symptoms of COVID-19, you have to follow all the personal protective steps to prevent infection. You have to follow a healthy diet, regular exercise. You have to stay hydrated and mobile. You have to take all your medications, including folic acid and vitamin D. Now, vitamin D cannot prevent an infection, but the studies have shown that the lack of vitamin D can make the person more susceptible to having the infection. As such, vitamin D is recommended during pregnancy, so you have to keep on taking it. But please make sure you have adequate supply of medication at least for a month so that you don't have to go often outside to buy it. Do not skip your prenatal or postnatal appointments. If you have an appointment and you are quarantined or you are in isolation, please call and talk to your healthcare provider so that your visits can be cancelled or postponed or switched to telemedicine or home visits. So we have to discuss and you have to follow it. Now, questions will be asked about fetal movements and mental health questions when someone visits you or calls you about usually in the last months of pregnancy. So you have to actually learn to appreciate fetal movements and count. You may have to buy weighing machine and BP monitor and learn to do it at home. And when someone asks you, then you have to tell your findings so that they can decide on your management further. If you have any emergency situations like severe abdominal pain or bleeding or leaking, which is related to pregnancy, you have to call your healthcare provider. And this includes any stress or fear or anxiety during this pandemic. Now, apart from that, suppose you are infected. So if you have symptoms suggestive of COVID-19, you have to self-refer. You have to go to the healthcare facility and get yourself tested. Please remember, if you're going to a hospital, you have to call them before you attend there. And as far as possible, you use your own vehicle. This holds good even if it is an emergency situation. If you cannot call or if you are unable to even make a phone call, please inform someone to call the healthcare facility so they're ready for you when you arrive there. When you are asked about history, you have to provide correct and complete history to the best of your knowledge, including your travel history. You have to discuss the management plans with the physician and give consents whichever plan is decided for you. Now, most important is to be informed. So you have to actually see the articles, whichever update is available, or keep on calling your healthcare facility to find out what else can be done. If you have any other problem, it is important to reach out to ask for help. Now, to summarize these things, personal protective steps should be followed to prevent an infection. Even if you are infected, do not worry. The overall risk to pregnant women is still very low. There is almost no adverse effect on the fetus, which we have seen. Care during pregnancy and childbirth, as well as postpartum period, is individualized. So you have to take into account all the factors before we decide that. Most of the transmission to the baby occurs after delivery. So we have to be very careful about this. And you have to seek assistance or you ask for help for your concerns or appointments during this pandemic. These are some of my references because this is overwhelming. I would like to thank the COVID warriors. This is one sister from our Omran hospital and another is one doctor in India. So they are working tirelessly to make our lives easier during this pandemic. And at the end, my dear ladies, you can do what I cannot do. That is personal protective steps, all these calling for help to make your appointments, reschedule, all these. All these you can do, I cannot. But you cannot also do what I can. I want to manage you perfectly according to the guidelines available. I have to update myself. I have to help you in all the other aspects. But together, we can achieve our goal. We can do it. And we can win over this pandemic situation to make the pregnancy and childbirth safer. Thank you, ladies and gentlemen, for the kind patient hearing. This is over to Dr. Kar.
Thank you, Dr. Rajni, for a very informative and clear presentation. Also congratulations for sticking to the time. As already informed, the question and answer session will be conducted only at the end of all 4 talks. So you are requested to put your doubts in the question section only. Now the next speaker is Dr. Malay Jhansi, who is working as Associate Professor of Pediatrics at RAC College of Medical Sciences. So she also works as a specialist pediatrician at RAC Hospital. She did her MBBS degree in 1991, diploma in anesthesia in 2004, and then MD in pediatrics from Rangaraya Medical College, Andhra Pradesh, India in the year 2010. She is a master trainer for facility-based integrated management of neonatal and childhood illnesses, facility-based newborn care, and also a mentor for online sick newborn course conducted by AIMS in collaboration with WHO India. She is also a reviewer for many biomedical journals. She has many national and international publications to her credit. Her topic of presentation today is pediatric COVID-19, an update. Over to you, Dr. Jhansi. You can start sharing your presentation now.
Thank you for your kind introduction, Dr. Subhranshu.
Yeah, it's visible. You can proceed ahead, madam.
This I have to minimize this one. Okay. Yeah, am I visible and audible?
Yeah, proceed ahead.
Yeah, thank you so much for your nice introduction. It is not going. During this presentation, I don't have any conflict of interest, and this material is discussed, whatever material discussed in this presentation is from journal articles, government websites. The evidence on COVID is evolving, hence whatever discussed is not a final version. I thank our President, Dean and Associate Dean for giving me this opportunity, and I thank Dr. Chaitanya, Dr. PG and IT department for their continuous efforts. My tributes to the frontline martyrs. My objectives are discussed. This presentation I discuss under the headings of epidemiology, pathophysiology, clinical presentation, and pediatric multisystem inflammatory syndrome. And what parents need to know, what is the neonatal COVID infection, what are the national guidelines, and what next. Coming to the epidemiology, the incidence of COVID infection in children is very less when compared to the adults, with incidence of 2% in USA, 1.2% in Italy and China, and Spain is reported 0.8% of COVID infection in children so far. Coming to the hospitalizations, adult children are less admitted into the hospitals than the adults, with 0.6 admissions per 100,000 hospitalizations, which is very low. Then this is the virus particle, which is the cause for now pandemic, which is a positive sense single-stranded RNA, which is the virus which is responsible for current pandemic, and the sputum saliva carry large amount of the virus. That is the reason infection is through the droplets. The virus is most contagious during the first 3 days after the onset of the symptoms. Spread can occur even 2 days before symptoms appear and in the later stages of the disease. So far, the incubation period is thought to be 2 to 14 days. Coming to the pathophysiology, this disease progresses through 3 stages. This is important to know because we know the progress of the disease so that we can predict the symptomatology, and we also can use proper medications to stop the progress of the disease, because we do not have proper medication and definite medication right now. So the virus enters into the respiratory system through nasal and oral routes into the respiratory system, where replication occurs in the type 2 nematode cells, which are surfactant producing cells. The point of entry is ACE2 receptors, which are very important point of entries. Some drugs like chloroquine and hydroxychloroquine prevent these ACE2 receptors and restrict the viral replication or viral entry into the host cells. Other organs which also contain ACE2 receptors are gastrointestinal, vessel walls, liver, brain, and testes. This testes acts as a reservoir for the virus, and which explains the high mortality in the male persons. And second stage is the virus is spread to the other lung tissue, which causes collapse of the lungs, lung tissue and causes decreased oxygenation, and the lung collapse will be seen in CT scans as a consolidation or ground glass appearance, which is important diagnostic criteria in deciding the severity of the disease. And when the virus is spreading to the other organs also infected, and because of other organs like GIT, vessel walls are infected, the symptomatology is different in different people, not only respiratory system, other systems also will show symptomatology. So the variable symptomatology is because of the virus infecting the other organs. The third stage is hyperimmune response. Whenever a foreign body like virus is entering into our body, our immune system starts eliminating the virus, but this virus causes hyperimmune response, causing the macrophages to release cytokines in a huge amount. This is the reason we call it a cytokine storm, which is the important factor which causes multiple organ damage. Important cytokines which are released are interleukins, out of which interleukin 6 is very important. The extent of organ damage is directly proportional to the level of interleukin 6. And however, this minority of children are progressing to hyperimmune response stage. That is the reason they are mostly less affected than adults. And why the children are less affected is another explanation. There is a difference in expression of ACE2 inhibitors, and qualitative response to the coronavirus is different when compared to the adults, which is another proposed hypothesis for asymptomatic and less infection rate in the children. Hence, many children may not present with respiratory involvement, but also other systems are, because other organs are involved, children may present with gastrointestinal symptoms like diarrhea and vomiting, intussusception and intestinal gangrene. Here, intussusception and intestinal gangrene are surgical conditions, and it causes a challenge in treatment by surgeons because we do not know whether these symptoms are due to incidental surgical condition or because of COVID infection. And other important findings are neurological, which child may present with convulsions and altered sensorium. There is no clear-cut evidence that COVID virus is causing these neurological findings, but whenever child presents with these neurological findings, with proper treatment, they recover without any sequelae. And another important finding in children is vasculitis. This vasculitis is very important, and it causes coagulopathy, and it also causes lesions like purpura, skin necrosis, and subcutaneous hematomas, and local infarction of the tip of the fingers, as it is seen in Kawasaki disease. We call it as COVID toes. And this multi-system inflammatory syndrome is another important manifestation of COVID infection in children, which causes very severe infection. It looks like a Kawasaki disease. Only the difference between Kawasaki disease and the disease caused by COVID infection is there is no thrombocytosis, which is seen in Kawasaki disease, is not seen in COVID infection. Children also presents with hypoalbuminemia, pleural and pericardial effusions. How you diagnose it? This is COVID infection is diagnosed. Gold standard test for diagnosis is RT-PCR. When RT-PCR is negative, that cannot rule out the diagnosis. If suppose child is presented with lymphopenia and high levels of CRP, ferritin and D dimers, which indicates the child is having severe disease. According to UAE national guidelines, whenever a child is confirmed or probable COVID infection, these are the infections mandatory to do. When a child is admitted to the hospitals, all these investigations are needed to monitor multi-organ involvement. So how the clinical presentation in children? Now currently the most common cause of fever, if you rule out other causes, it is definitely due to COVID infection. So pediatric patients with COVID infection may experience the following signs and symptoms. There are so many signs and symptoms. And one thing you have to remember is I'm unable to move yes. These children with COVID infection may not initially present with fever and cough. Many children are asymptomatic in nature. In one large study, it is shown that 13% of the children are asymptomatic. Because of asymptomatic nature, many children are not being tested routinely. That is the reason we do not know the exact prevalence of asymptomatic COVID infection in children. What are the clinical types? It presents as a mild disease with mild upper respiratory infections with positive RT-PCR, and there is no abnormal radiographic and septic presentations. In moderate disease, child may present with mild pneumonia. In severe cases, in addition to the mild and moderate symptoms, child may present with rapid breathing, hypoxia, loss of consciousness, dehydration, and elevated liver enzymes. There may be a coagulation dysfunction also. Another condition which is very less in number are critically ill cases, where the child may present with acute respiratory failure, and septic shock, and organ failure. These children are requiring ICU management. So in a large study, it was shown as 4% are asymptomatic, 51% are having mild symptoms, 39% are having moderate symptoms, 5% are having severe symptoms, whereas only 0.6% children may go into critical condition and which require ICU care. And regarding the age distribution, less than 1 year of age children are more prone for hospitalization and severe infection, and especially with the children with chronic lung diseases and cardiovascular disease and immunosuppression are more prone for severe disease. And what is the accepted treatment which is based on the studies? UAE guidelines, according to AE national guidelines, the treatment consists of, when the child is asymptomatic, there is no treatment, and other drugs which are approved are hydroxychloroquine and chloroquine sulfate, which is used in mild to moderate cases, and favipiravir and lopinavir ritonavir combinations are antiviral drugs which can be used when a child is having with severe disease with respiratory compromise. And another immunomodulators are tocilizumab and nebulized interferon alpha-2b, interferon beta-1b are used as immunomodulators. One thing we have to remember is whenever these two drugs are used, they should not be used in combination. Whenever child is taking interferons, when you want to start tocilizumab, you should stop the interferon at least for 24 to 48 hours. Then only you should start tocilizumab. Once you start the tocilizumab, you should never restart systemic interferon, because these two are very toxic drugs, and these drugs should be used with a consultation with an ID specialist. And what parents must know regarding multisystem inflammatory syndrome in children. It is a condition where different body parts can become inflamed, including heart, lung, and kidneys. However, we do not know the cause. However, when the children are having this inflammatory syndrome, it is very serious and even deadly. But when diagnosed properly and treated properly, these children will recover very nicely. So what the parents should know? Whenever child is presenting with fever, abdominal pain, diarrhea, neck pain and rash, and conjunctivitis, just think about these symptoms may be due to multisystem inflammatory syndrome. What are the emergency signs? Emergency signs are trouble breathing, child is taking breathing very difficulty in breathing, and the child may be having pain or pressure in the chest. There may be a confusion, child is unable to walk, child is unable to wake up from the sleep, there is bluish lips or face, and then in such situations you should seek an emergency care immediately. So coming to the treatment, there is no published guidelines or CDC recommendations regarding the treatment, but supportive treatment is needed because child is under shock. So fluid resuscitation and inotropic support is given. Anti-inflammatory drugs, intravenous immunoglobulins and steroids and aspirin are used. The good thing is there have been very few cases of deaths reported in hospitalized patients. So According to UAE national guidelines, you exclude any septic shock, which is the reason for the serious condition of the child. So start resuscitation with the fluids 10 ml per kilo. If there is no improvement, start inotropes, and along with inotropes, child should be on antibiotic, broad spectrum antibiotic, because we cannot rule out any septic shock. Early starting of IVIG is preferable. When the child is managed in PICU, all healthcare workers should take personal protective equipment, can take care of themselves, and use a central line. Temperature should be monitored. IVIG should be given. When IVIG is given, you have to monitor overload of the circulation. Methylprednisolone is the cornerstone of the treatment for ARDS, and give proton pump inhibitors and aspirin. Whenever therapy is started, see when any fluid overload and give diuretics. If the child develops any hypertension, treat with calcium channel blockers. If hyperglycemia is present, they require insulin infusion. Gastritis is treated with PPIs, and salicylates may cause acute kidney damage. So coming to the neonatal COVID, as already Dr. Rajini told, the infection in newborn is only 3% with negligible mortality so far. The common presentation is asymptomatic, and respiratory distress is 4.7%, pneumonia 1.2%, and disseminated intravascular coagulation is 1.2% of children. And it is generally acquired through postnatal transmission rather than vertical transmission, but there is no proper evidence. There are 2 case studies which shows that vertical transmission may be a possible, may also be possible. So newborn infants with COVID infection exhibit either no symptoms or mild respiratory illnesses. And why these children are showing mild respiratory illnesses is because of immaturity of angiotensin converting enzyme receptors, as well as fetal hemoglobin, which is protective against this COVID viral infection. When a mother who is confirmed and suspected COVID delivers, and see whether child is asymptomatic, and if it is asymptomatic, test for COVID test. If suppose newborn is COVID negative, go for routine care and rooming in, give normal breastfeeding, and routine follow-up is required. If asymptomatic child is COVID positive, you have to give a routine care and rooming in with breastfeeding. Take the necessary aseptic precautions not to transmit the disease to the baby, and the child should be followed up after 14 days. When a child is symptomatic, this child may be a COVID negative or COVID positive. When it is COVID negative, the symptomatic newborn may be having other than COVID infection, which is requiring NICU admission. So routine guidelines are used to treat this child. If suppose child is COVID positive, you have to admit the child in an isolation or closed incubator in a negative pressure room. All healthcare workers should use PPEs and minimize the aerosol generating procedures like closed ET tube suction, and prefer CPAP, and discharge the child whenever child is eligible for discharge, but do a follow-up as needed. These are the guidelines taken from the UAE national guidelines. The same thing is represented here also. Screen the children after the 24 hours. If a child is delivered to a COVID positive mother and admitted to NICU. If child is negative, repeat in 48 hours. If still negative, consider this child is negative. If the child is positive, repeat after 72 hours. If it is negative, consider it is a negative. If it is positive, again repeat the test. Whenever you discharge a newborn, when the mother is still positive, you have to follow up the child for COVID positive in the follow-up. And whenever child is admitted to the postnatal ward, screen the child after 24 hours. If it is negative, you keep the baby with the mother. If it is positive, repeat after 72 hours and follow the flow chart. And there is no specific treatment for neonatal COVID infection. Only supportive care is needed as per the problem identified. So regarding the breastfeeding, WHO UK guidelines and Indian guidelines says rooming in with mother is preferable with breastfeeding and taking necessary precautions to avoid the transmission of the disease to the newborn. Whereas the AAP guidelines prefer separation of the baby from the mother and give the expressed breast milk. CDC says case-to-case discussion regarding the breastfeeding is considered. And what are the social effects of the COVID infection pandemic on children? The social impact is very huge, and because of defaulting of the routine immunization due to lockdown in developing countries, there is an increase in outbreaks of the vaccine preventable diseases and deaths due to measles. And government, even though introduced several e-platforms for making education accessible to the children, there may be no uniformity in there is no uniformity to the children with special needs. So the management of chronic and acute medical and surgical non-COVID infections are hampered because of lockdown. And there is a huge psychological impact on child psychology and adolescent and child psychology due to this pandemic. And there is surprisingly 50% increase in child abuse during this period. And street children of migrant laborers are exposed to significant challenges in food security and health. Then what next? When it will end? Definitely it will not end. We have to choose some vaccines to contain this infection to prevent the
2 minutes left.
Yes, thank you. So there are so many steps involved in this testing, from preclinical testing to the approval. The vaccination goes through so many steps. There are so many vaccines available. There are so many trials on genetic vaccines, viral vector vaccines, protein-based vaccines, and whole virus vaccines. Another important is repurposed vaccines. Here, repurposed vaccines are already vaccines which are used like BCG and MMR are studied for the protection against the COVID infection. So there are 165 trials on vaccination is going on, of which 6 are in phase 3 trial. 1 is approved for limited use in the Chinese military. Then there are so many researchers are working on preparing vaccination, and we are expecting a fast track vaccine to be available by June of 2021. And regarding UAE, UAE is going under vaccine trial with China, and already 15,000 people are recruited for this phase 3 trial, and volunteers can register on the government website by calling these numbers. And scientists are hoping the trial will help determine specific antibodies that can fight the virus and provide immunity. So till we find a proper solution, our responsibility is to stay at home and wash our hands. Do not put your fingers in mouth and maintain social distance, avoid handshaking, and observe proper cough etiquette. Thank you.
Thank you, Dr. Jhansi, for a lucid and interesting presentation. You also had 20 minutes with you, and you amply used that for the presentation. Now the third panelist for today's webinar is Dr. Talat. Actually, he does not need any introduction. He is a very senior consultant psychiatrist and is well known throughout the Gulf countries and beyond. He is currently working as Professor of Psychiatry, RAC College of Medical Sciences, and also as a consultant psychiatrist at RAC Hospital. He did his MBBCH in 1977 and master degree in neuropsychiatry from Cairo University in 1983. He got a medical doctorate in psychiatry in 1999. He is an esteemed member of the editorial board of World Journal of Psychiatry, the Arabic version, and member of editorial board of World and Arab Journal of Literature. He has translated 3 books in psychiatry and psychology and has got many publications in national and international journals. He will be talking on the effect of pandemic on mental health. You can start sharing your slides, Dr. Talat.
Thank you very
Over to
much,
you, sir.
Dr. Kar, for your introduction. And I hope, good afternoon, everybody. And I hope you are still awake. And I think all of you know that everything in our life will affect our mental health. Everything will affect, and no need to say that the pandemic has affected severely the mental health, and we don't know in the future what will be the case. And in the beginning of the pandemic, I didn't notice any change in my clinic. You see the panic of the people, and I attributed that to what is called the herd security, like the herd immunity, herd security. The people, if the impact is all over the people, so the people are independent on each other. There was no increase at all of the psychiatric uh, cases in the clinics, and I asked all my colleagues and all over UAE, and they reported the same. But after some time, the condition started to appear when the people had got the infection and recovered from the infection, and even people who have not got the infection. So, what is the impact? What is the reason of that? All of you know the WHO guidelines isolating all people, tracing contact, quarantine of exposed people, school dismissal or closure, and the change in the workplace, avoiding crowds. All these were the instructions. All these guidelines affected three main spheres, and all three main spheres are interrelated. They are interrelated: psychological, social, financial, both affecting the mental condition. So financial, loss of job, reduction of salaries, closure of business. Many people, and needless to say that there are many people who lost their jobs, and many people who lost their business, and many people who closed their business even. And this is one of the serious condition happening in this uh, pandemic. And of course, the psychiatrists and Scientologists go directly to do research and the statistic and see of what is seen. They want to put it in a documentary way, manner, or in a scientific way, uh, so that there is a clear correlation between people who lost their jobs and people who have psychological problems. Then the second sphere is the social distancing. And you know that we are a social animal, a human being. We are just a social animals. We cannot live alone in this cosmos. So social distancing affect, although I don't like the term social distancing, I prefer the term physical distancing. Also physical distancing, physical closure, physical interaction is very important. Is very important in our psychological life. So the physical distancing has done a serious impact, as we will see later on in this lecture. Then the lockdown and the interpersonal conflict, that now the people started to discover their partner. And sometimes people live with their partner or their children without true relationship. They believe that they are lovers, but they are not. They believe that they are good parents, but they are not. They believe that they are one family, but in fact they are not. And this is put us in a test when we sit together, when everybody sits with his partner, and everybody discover maybe for the first time after many years the true personality of his partner. This is what is the impact. Of course, there is one. Of course, there is benefit for the social distancing, and you see here, if without social distancing, that one person after 60 days may infect 400 person, but with social target only can infect 2.5. So there is no question, because many people are questioning the social distancing
Dr.
effective
Talat,
or not.
Dr. Talat,
Yes.
sorry to interrupt you. Can you speak little loudly?
Okay, or can I put the microphone?
That's better because your voice is, not heard properly.
Okay.
Thank you.
Now you hear me better? Hello? Dr. Sobrancho.
Yes, sir. Now you are okay. Please proceed ahead.
Better now?
Yeah, better.
Okay. Okay, then, in spite of the importance of social distancing, but it has impact. We tried to trace the effect and the reaction of the people to this social distancing. And the psychologists found that there are 5 stages. The first stage is disbelief. This is a nature of the human being. When we face a disaster, when we face a problem, we tend to deny it, disbelief. This is the first stage that people face. The second one is the optimism. Oh, okay, this will be very temporary, and inshallah it will end soon. So this is the optimistic stage. Then we have to accept. We accept. Then we feel sad because we don't know when it will end. Then the sadness will return to anger. Then we become angry, and sometimes we protest, and this anger might be displaced in the person around us. And this is one of the reasons of the interpersonal conflicts happening after the social distancing or the lockdown. Then, what are the negative impacts of the lockdown? There are many, all of you know that there are many negative impacts of the lockdown. Financial, education has been affected. The feeling of loneliness, as I told you, we are social animal, and loneliness is the most stressful thing for mental health. Then the health problem, weight gain, lack of exercise, the unavailability of the health services. It was very difficult for people in the early days of the lockdown. I received many calls from my friends if they have any problem in their stomach or in their heart, where they will go. And the substance misuse, and the statistics said that the increase of the alcohol consumption increased by 170%, 170% than before the lockdown. And the interpersonal problem, of course, as we told, and the domestic violence, which emerging problem emerging after the lockdown, and the feeling of boredom, I think, which all of us have some some in the early stages of the lockdown, people did some research and they found up to 45% of adults felt adverse effect on mental health. 70% felt this period was the most stressful career in their life, and about 40% showed signs of psychological distress. What are the psychological distress? Why? For many reasons. As I told you, it is a very vast topic. It is a very big topic. I cannot include it or contain it in one lecture, but I will give outlines. Number one, fear of infection. And by fear of infection, we mean the pathological fear of infection, because all of us has fear of infection. I personally fear of infection, and everybody has fear of infection. But when the fear exceeds and hinder our daily function, it's called pathological fear of infection. And then worry about us, not only us. Everybody is worried about his people in either in this country or in his home country, and this make us guilty, feeling guilt because we cannot do anything, especially if we know that they have got infected. Then the most stressful is the grief grief. I received many patients in my clinic who lost their some member of their family in their home country. Then the quarantine of suspected cases also would make up loneliness, make up rejected according to the psychological setup of the patient. Some people who have their original belief that they are rejected, when they become to the quarantine, oh, this will be exaggerated and it might lead to depression, even suicidal thoughts. Isolation and hospitalization is very stressful because in the early stages, they were even not allowed to talk to their family. And then the recovered cases, I will talk about this later on. And this is just to show that the fear of contacting is increasing by time. And in the beginning, it was only 41% who were scared, but in the later on in April, they increased to 60%. That the fear is increasing. There was a review of 43 studies. 43 studies, meta-analytical studies, found that COVID-19 patients displayed high level of post-traumatic stress disorder. And for those who don't know what is post-traumatic stress disorder is a psychiatric disorder occur after people witness a life-threatening situation. It is a very serious one, and it leads sometimes to suicide. Patients with pre-existing psychiatric disorder reported worsening of their psychiatric, which we were worried about our patient, what our patients who are already psychiatric patients, where they will go. Higher level of psychiatric symptoms were found among healthcare workers. This is also one issue. A decrease in psychological well-being was observed in general public. However, well-conducted large-scale studies are highly needed. So what we need and what we are doing now, I am a part of a very big research, international research, to see the impact of COVID-19 on the public health and on the community. It will tell many countries, European and Arabic countries. And I think we are still now in the recruitment phase, and we'll show you on another occasion the results which you will find. And this some survey also so that the most prevalent symptom was insomnia, poor appetite, frequent headache and somatic symptoms, and temper control difficulties, increased alcohol abuse, worsening of chronic condition. These are the most apparent psychiatric symptoms. And also, it was well known in many studies that the most important psychiatric disorder was anxiety. If you see here in May, in comparison to January, see how the difference was, maybe triple, and also the symptom of depressive disorder or maybe quadruple, 4 times more than the normal situation, and also symptom of anxiety of depressive. By symptom of anxiety or depressive mean that they have not full criteria, but they have symptoms of the anxiety and depression. This is the report of the Mental Health America data. They said that conducting online screening, they usually every year they do statistics to see how many patients have developed new psychiatric disorder, and they started to compare the people before the pandemic from January and from February onwards. They started to compare, they found, and they did some questionnaire. The most profound health problem were found among adults younger than 25. This is very strange that we were expecting that the older people will be more affected because they are the ones who are at risk of getting severe disorder. But all of the studies found that the younger people are more affected than. It seems that when we become older, we become indifferent to either a stressful situation, either pleasurable or sad even. Or maybe because we are more wiser and our expectation is that roughly 90% screen positive for moderate to severe depression, 80% screen positive for moderate to severe anxiety. And the kids at the age between 11 and 17 have been the most stressed, maybe because of the isolation and because of the panic they see in their families. Loneliness and isolation were cited as contribution to depression and anxiety. One of the most important causes is loneliness and isolation rather than the fear of infection. In June, roughly 25% of participants also cited grief or loss and financial concern as contributed to anxiety. A dramatic increase in the number of people who reported being at risk of psychosis. This is the most important, that the people who are borderline, and when they screened for in March, April, and May, they found that they increased a lot the risk of psychosis. In June, 25,000 and half participants who screened positive for depression reported thinking of suicide or self-harm on more than half of the days to nearly every day. That means that there was risk, and I think all of you heard about many people even among the health professional who committed suicide. This is not because of the fear of infection. This is not because, no, this is because of the multiple factors like isolation and this. These are the most vulnerable people who are vulnerable to psychiatric disorder, patient with depression, patient experience agoraphobia, patient with OCD. I don't like to bother you with all these terms, but the already psychiatric patients are more vulnerable to be stressed. But this is not because of the disease. Now, if we know that this every 45 seconds there was one death due to COVID, but every 40 seconds we hear, if you remember the suicidal day, when we say every 40 seconds we hear about a suicide. So this is not a big number of people who died, but this is because of the media and before the halo effect of the confusion associated with this pandemic. Is there any relation between psychiatric condition and inflammatory biomarker? That's what, as a scientist or as a psychiatrist, we have to say. If this is due to stress as a reaction to the fear or the isolation or this is due to some organic changes in the nervous system, and all of us know that it affects the nervous system. Cosmia or loss of, huh?
Sir, you have 2 minutes more.
Okay. Is there any relation between this and this? We know that it affects the nervous system. One of the symptoms is loss of taste and loss of smelling. That means that it affects the olfactory bulb of the brain. So this one of the studies found that there is no relationship. Although there was the basic inflammatory marker were higher among male, but the psychiatric problem was more in female than the psychiatric male, in spite of this. The baseline inflammatory marker as well as follow-up oxygen saturation also did not correlate with this. So until now, we did not find a correlation between the organic changes in the nervous system and the psychiatric disorder. The problem after recovering of infection, we have mixed emotion, including relief, fear of worry about one's own health, stress from experience of having COVID, sadness, anger, frustration because friends or loved one have fear of getting there, being rejected, guilt about not being able to perform normal work for parenting duties while they had COVID-19. This is worry about getting reinfected again, other emotional or mental. From my clinic, patient with an anxiety and fear. This is what I have seen after the 2 months of the start of the pandemic. I saw people with an anxiety, fear of infection. I saw people of grief reaction. I saw people which developed PTSD. I saw patients who developed depression, severe depression, for the first time in their life. And I saw people who developed dissociative conversion disorder and start to be histrionic and show convulsions. I don't like to go more because I still have so many to tell you, but Dr. Carr will not allow me. Not only that, not only the illness which affects psychiatric symptom, but also the medication which used for the treatment has its side effect, has its psychiatric side effect. And I think we can make it in another lecture in other time that we have to worry about the side effect of this medication, and also we have to worry about the interaction between this medication and our medication. And I will go quick to see that there are some medication as a psychiatrist we should think of it, like lithium, clozapine. Clozapine will reduce leukocytes and will reduce the immunity. So we have to stop immediately any people who are on clozapine and got infected with. Also, lithium also will affect this, and because it affects renal function, it affects the hydration, and the long-acting neuroleptic also we have to think of it. We have because the discontinuation of it will have severe relapse. This is there are some medication which are least hazardous, like in anxiety, for example, SSRIs like sertraline. Insomnia, we can use quetiapine. In agitation, we can use halobrodine, but we have to look to the drug-drug interaction with the antiviral, with the antimicrobial, and with the heparin and the anticoagulant. Very serious to give SSRIs with the anticoagulant. So the psychiatrist should be worried about that. And now there is say that our psychiatric medication might help in preventing the worsening of the symptom, not only the psychiatric symptom, but the COVID symptom, the infection, because it is well known that SSRIs have antiviral effect, and also it affected the immune system, and also it affected the aggregation of the platelets. So many people now recommend, but just hypothesis. This is one of the papers studied this, but this is just hypothesis and a suggestion for people to use this. And there are starting some studies to see the effect of adding SSRIs to the regime of the treatment of COVID to alleviate the symptom, because it affected the, as I told you, the aggregation of the platelets, the immune system, and it will prevent the cytokine storm. I think I can stop here, but just I want to remind you of the 4 pillars for mental health: sleep well, eat balanced diet and healthy diet, make physical exercise, and try to manage your stress. Thank you very much, and I'm willing to answer any question.
Thank you so much, sir. Actually, I know your talk actually needs 2 days of webinar, not one session of 20 minutes.
Yeah.
So thank you for the very clear and informative talk, sir. Now it's my honor and privilege to introduce the last but not the least panelist for today's webinar, Dr. Abdul Basit Ishawi. Again, like Dr. Talat, he does not need any introduction. He is a very well-known academician and is currently working as consultant nephrologist, Saif Hospital, Ras Al Khaimah. He is also the Associate Dean Clinical Training and Adjunct Professor of Internal Medicine, Rakcoms. During his stay in France, he has obtained more than 6 subspecialty diplomas in immunology and medicine. So from this, you can know how interested he is in academics. Currently, he holds the position of the President of RAC Update in Nephrology and Transplantation Meeting Series. He is also an esteemed member of the editorial board of many journals and has got many publications in national and international journals. He will be talking on his personal experience in a COVID triage tertiary care hospital. Over to you, Dr. Ishawi.
Hey, thank you, Dr. Sobrancho. Thank you. Do you hear me?
Yes, sir.
Hello?
Yes.
Yeah, thank you very much, Dr. Sobrancho, for this kind and generous introduction. However, I'm a consultant of internal medicine also. I have double consultant license, internal medicine and nephrology. So today I have been following the webinar and the last 2 series, And unfortunately, the timing of the webinar came with the timing of going out of work and reaching home. So I usually catch around 4 p.m. This is the time I came. And based on the 2 previous webinars, I found myself desired to give you some clinical and practical experience rather than a theoretical one. So just to tell you, when I came back, I was away when they do the distribution. So my location was in Sacra Hospital to cover both nephrology and internal medicine because our staff has been divided in two. And as I have a double license, internal medicine and nephrology, so I was ideal fit to cover two specialty in terms of shortage of staff. So I was working like 2 staff in one. And I established in Sacra Hospital, when we started over there, our emergency medical used to receive all those cases who are suspected of COVID. And we were admitting them in normal ward. And it happens that the ideal precaution against protection of COVID was not there. And it turned out that we have 2 colleagues who got positive within 1 or 2 weeks after we started our activity in Sacra Hospital. So I wrote a warning to everyone of the administration, very clear and straight, and it was even dangerous for me. It could jeopardize my work. I said, if you continue like this hospital will be closed within 1 month, because if you have 5 doctors and 5 nurses already got positive and you do contact tracing and isolation, you will isolate the whole staff and there will no one to treat patient. They listened to me and we established isolation units, 16 bed in Sacra Hospital. And in face of large number of patients of high suspicion, our capacity went up to 24 cases in 16 bed because we had to put 2 cases similar to each other in one room. So when we received the patient in the emergency, we did a triage for the patient with suspected COVID into mild, moderate, and severe. And this depends on the presentation. So, and the presentation and clinically on the high resolution CT and the biochemistry. So we have more mild, moderate, and severe. And our diagnosis for cases moderate and severe, highly suspicious COVID-19, we had an accuracy of 90%, and those 90% was converted, was proved to be positive later on from the first sampling. And because we were confident from our high suspicion, we did the second sampling and it came positive. So we divided the cases into mild, moderate, and severe. And this depends on, for example, those who come only with fever, no other symptoms, or cough, and CT is okay and laboratory is okay. We consider them, as long as they have fever and cough, this is mild. And this is, I will explain to you later how we treated them. Moderate and severe, those who have more symptoms, who have a fever, who have laboratory presentation, and they have CT finding. What was a fever and a cough, and what was the laboratory presentation? It was very typical, which you have leukocytosis, and you have neutrophilia and lymphopenia. You have elevated LDH. You have elevated liver enzyme. Some of them come with rising of serum creatinine, acute kidney injury. You would have elevated D dimers. You have elevated LDH. You have elevated CRP. You have elevated procalcitonin. So with combination of 4 or 5 of those, in addition to the typical clinical CT finding of COVID-19, which is a peripheral subpleural ground glass opacity, so we consider them moderate to severe. So for the mild, I will come to the treatment part, and then I will explain to this. So we have mild, moderate, and severe based on clinical presentation, fever and cough, laboratory presentation, which is neutrophilia, lymphopenia, elevated LDH, elevated D dimer, elevated liver enzyme, elevated serum creatinine, elevated CRP, elevated procalcitonin. You don't need to have all of them, but you can have 4 or 5 at a time. And the most interesting thing is that we described it, and we have a few case reports, but unfortunately from the workload, I was not able to send it for publication yet, but we reported it as early even before it show up in any journal or in the media. This is a patient who come to the ER with cough and fever, but the patient was sitting well, talking, eating, and he's putting his mask. And when we measured his oxygen saturation was 84%. So I have Dr. Ala Uzmay, I told him, this oximeter is wrong. Just repeat it again and again. It came also even with blood gases, the saturation is low. And this is the CT finding. He has pneumonia, and he has, this is what's called the peripheral subpleural ground glass opacity typical here on your upper right quarter. And this is show you some pneumonic patch, and the patient feel well despite the saturation is 84%. And we called it silent hypoxia. And so because the patient doesn't feel anything. So this was our finding, but unfortunately we were not able to send it for publication. Hopefully we'll have time soon, but some people reported it. So the interesting thing was the oxygen saturation 84%. The patient doesn't feel dyspneic, eating, talking, even putting the mask. This is one of the beautiful findings that we found it. And then by that time, I made a protocol for all the first on call in order, because we have like 20 patients at a time and they keep call us at night. So I made a protocol adopted from my reading and also from the national guideline. As you can see, I send it by WhatsApp. You start hydroxychloroquine, and then you add azithromycin, and you can use favipiravir, and you can use Calitra, which is lopinavir and ritonavir. So I used to use hydroxychloroquine, and then later on we added azithromycin, and then in combination with favipiravir and lopinavir, ritonavir combination. I used to use in the isolation units 3 antiviral, this 3 antiviral. And also we used to use low molecular weight heparin, because all these people come by elevated D dimers, and some of them develop microthrombosis and macrothrombosis, and we have seen numbers of D dimers that I never saw in my life, which is 20,000. So I used to send all this thing to the first on call in a group, and then even how we can use the anticoagulation. Because I see the presentation of Dr. Suresh last webinar, he's highlighting anticoagulation as a symptomatic treatment. No, this COVID-19 is a thromboembolic disease, and most of the complications coming from the thromboembolism and the microthrombosis, both in the lung, brain, and even in the heart. And it can have even presentation with gastrointestinal presentation. So up here, I will come to this later, how I send it to my first on call. So when they receive 3 or 4 cases at night, they don't call anyone, they know what to do, starting a medication from moderate to severe. Mild, we used to give only hydroxychloroquine, and this is a protocol of anticoagulation. And then when some publication comes later tell you that pro-BNB, NT-pro-NB is associated with high mortality. So I ask it to the first on call, and also I send it to our ICU doctor, telling them that this is what we do and our first on call do. So as you can see here on the screen, I add NT pro-BNB to highly suspected cases because it is associated with mortality. You can see also in the lower left lower hand quadrant and the susceptibility of the PCR in diagnosing COVID-19. And this is why with this susceptibility, we had to repeat the test 1 time and 2 times. And it's a funny thing, is a guideline of the ministry tell you have to do the PCR 1 time and 2 times. And we have one of our colleagues was diagnosed with the 3rd PCR, and we have patient was diagnosed with the PCR. But we found ourselves early in the disease. The PCR used to take 3 to 4 days. And if you do 1 PCR, 2 PCR, your patient already finished 8 days. And we already finished the protocol of treatment because this antiviral is only for 5 days. So, and then few of them come diagnosed at the 3rd sample, and then we told them no, we will follow the national guideline, only 2 samples. I will never do the 3rd sample, even we have some cases diagnosed after the 3rd sample, and I showed you the sensitivity of RNA, RT-PCR here, how much they are sensitive. This is how I used to
Sir, 2 minutes.
Okay.
Sir, 2 minutes for question and answer session after that.
And then here also, I showed to you what I summarized about the COVID-19 as every patient have a COVID-19 positive, he will be cleared the virus and after 14 days. And only symptomatic patients are admitted to the hospital to treat complication. So far, by far, no treatment proved efficient in treating COVID-19, no drugs. So after 14 days, every patient will be negative, whatever you treated or not. So we admit the patient to treat the thromboembolic complication or cytokine storm. And the protocol of Ministry of Health is to discharge the patient after 2 samples negative. And I think I will write to them to change this, because most of the patient still having complication after becoming negative, which comes continuously. And I sent it to this was posted in all hospital groups, and to tell them at that time, which was end of April, that everything, nothing is effective, hydroxychloroquine or. Regarding the treatment, so anticoagulation is not a symptomatic treatment, is a part of the treatment because it is a thromboembolic disease. So I will not go through the details. And in order to, very interesting to tell you, as pneumonia and sepsis are often complicated by DIC, but COVID-19 patients, they have atypical DIC. Their DIC is associated with elevated D dimer, but there is no drop in the platelet and there is no prolongation of the clotting time. This makes the DIC of COVID patient completely different from DIC that we see with any infection. And the sign of the site of thrombin and fibrin formation, it seems to be local in the lung. And this is the protocol. I will not go to that. I'm just showing you when you have a patient who's a critically ill and patient not critically ill. So when it's a critically ill, you depend on D dimers and levels, and then you start the dose of heparin as a prophylaxis, low molecular weight heparin, and you modify by kidney function. And also, if the patient not chronically ill, the dose is different and depend on BMI, and you modify by the kidney function. Those who already on anticoagulation, you go ahead. And the anticoagulation have to be extended 2 to 4 weeks after discharge of the hospital. And this is the protocol we are following in the Ministry of Health. I posted it for each doctor WhatsApp. Here's the point of hydroxychloroquine and the tocilizumab and the extracorporeal therapy. I will be fast here. The idea of hydroxychloroquine is not to treat, it's just blocking the antigen processing that stimulates the cytokine storm. So it blocks the antigen processing and B cells, and blocks the antigen processing in antigen presenting cells. So it blocks the first step of immunological reaction to the COVID-19. And this is the whole idea which was successful in experimental animal, but never proved efficient in human as this study, and we stopped using it completely. By now, we don't use hydroxychloroquine. Tocilizumab, we use it when there is evidence of cytokine storm. And extracorporeal therapy, there is absorption column. It is debatable because you remove the harmful cytokine and also you remove the beneficial cytokine with it. And this is to mention for you what is available. This might be the last slide. What is what is available as an antiviral? Remdesivir, lopinavir, ritonavir. I spoke about, none of them proved effect. None of them proved effective. None of all antiviral we're talking about is proved effective. And this is the 6th step of viral application. Whatever. Lopinavir, ritonavir, remdesivir, none of them effective. Camostat recently under trial, it prevents the union of the virus to the receptor. Monoclonal antibody and convalescent plasma proved a little bit effective. The only medication who saw some benefit is remdesivir, not on mortality, but a number of hospital stay. It reduced it by 5 days versus placebo. No effect on mortality. So far, nothing is effective among those, and there is a trial going. And this is the last slide, and this is the last guideline, and they tell you how to use favipiravir, lopinavir, ritonavir, which is Calitra. Just to let you know, Calitra or this medication cause elevated lipase and the pancreatitis. It causes elevated liver enzyme, is very toxic. Interferon alpha 2 beta, we started to use it, but we use inhalation because subcutaneous, when we use it, we already anticoagulation in the patient. Ribavirin, I've mentioned in one study, Hong Kong study, combination of Calitra, lopinavir, and the interleukin-1 beta and the ribavirin. This one which we used was interferon gamma in treating hepatitis B. Remdesivir, I just talked about. Steroids proved to be only efficient in those patients who COVID positive and require oxygen, either by mask or ventilator. Those who are asymptomatic have no value or didn't have any benefit in terms of the steroid. Anti-IL-6, controversial. We use it in patients when the IL-6 level is more than 5 times elevated, and convalescent plasma is still under trial, but it seems showing some benefit. Thank you. This is my tips from my experience in Sakra Hospital before we transfer the cases to COVID Center in Ubaydullah Hospital. Thank you.
Thank you so much, sir, for your nice elaboration of the recent treatment guidelines and your suggestions to the Ministry of Health. It was really very, very informative to know. Now we are going to start the question and answer session. So I want all the panelists to be live, and please switch on your webcams. Because of the lack of time, I request all the panelists to be very brief in answering the questions. The first question is for Dr. Rajni. If a neonate is tested positive on the first day, how to know the infection is antenatally acquired or it's a postnatal infection? Please be brief in answering to the point.
Yeah, thank you for the tip. But we have already seen, as seen with other infections, that the amniotic fluid does not contain the virus. Even some studies, they have shown that the amniotic fluid may contain the virus. Even if it is present there, the fetus does not have enough receptors. So there is very, very little chance that the fetus will be infected in utero. Second thing, just after birth, within 12 hours, if you do a test and it is positive, it is most probably acquired during delivery. We repeat the test after 48 hours. If both the samples are positive, then this is acquired during delivery. If only the second sample is positive, then it is most probably the postnatal transmission. In all the studies which we have seen, the most common mode is postnatal. So we are not very much worried about the antenatal or intranatal transmission. Thank you. I hope that answers the question.
Okay, thank you. And the second question is for Dr. Jhansi. Is it safe to use corticosteroids among pediatric patients for the management of COVID-19? If yes, which all parameters need to be monitored? Dr. Jhansi.
Yeah, when the child is very sick and critically ill, we need to use steroids to decrease the inflammatory response. And when you are using methylprednisolone, only one side effect is hypertension. So you need to monitor hypertension. And if suppose child is having hypertension, better use calcium channel blocker, or if it is very high, SMP is used, sodium nitroprusside.
Okay. Now the third question is for Dr. Talat. According to your experience, what do you recommend for patients with depressive illnesses who have acquired COVID-19 infection? Sir, you can answer. Dr. Talat, please.
Yes, people who had depressive disorder before the COVID, I think they are already protected by if they are taking their medication, and as I told you, the SSRIs are even protective for the infection. And for those people, we advise them to continue taking their medication and to come for consultation. And they try to prevent me from seeing my patient in Rakk Hospital in the days of the pandemic, but I refused completely they were afraid that because of my age, that I could be in risk. But I insisted to see my patient face by face, not online. Just this is what they need. They need support to continue their medication. Sometimes, if they are in remission after the COVID, some people they get relapse. So we have to give them again the antidepressant with the support of psychotherapy. I think this is the most important. Most important is to support and support and support.
Right. So another question is in the same line, and you have answered this question, so there is no need to ask the same thing again. Now, again, the question is for Dr. Rajni. Does the use of corticosteroids have an effect on the labor if a pregnant lady with SARS-CoV-2, since it promotes fetal long maturity? Will it have any effect?
Yeah, because there's chance for preterm labor in COVID infection. So we do give steroids, that is dexamethasone or betamethasone for fetal lung maturity, but that is only one course. So what happens if you go on giving dexamethasone or betamethasone, it is going to be transferred to the fetus and it will cause fetal effects. So apart from the role of pulmonary maturity, we do not continue dexamethasone or betamethasone. Rather, we would use prednisolone or methylprednisolone, which is effective, but it does not have transplacental transfer much. So if you are giving it for lung maturity, you are using dexamethasone or betamethasone. But if you are using it for the mother itself, because she needs oxygen and you have to give steroid, prednisolone will be a better choice.
Right.
Keeping in mind the fetal safety.
Now you can answer here itself. What does BAME stand for the high
risk? That was a British study. So they have divided the population into British and non-white population. In non-white, they have Black, Asian, and ethnic minority ethnic groups such as Hispanics. So that's why they have quoted the BAME. That was a British study.
Yeah, okay. Now this question is for Dr. Jhansi. What are the different treatment modalities for management of infection in COVID-19 positive newborn? I think you have already elaborated that.
There is no specific treatment, actually only supportive treatment. So far there are no drugs that are used for COVID newborn infection because it is treated like a symptomatic case.
Correct. Now the question was actually asked to Dr. Jhansi, but I think Dr. Talat will answer it better. So the question is, how do we physicians bear the burden of conveying the progress and convincing the parents to permit us to carry out the treatment options when they are already in an unpeaceful state of mind? So Dr. Talat can highlight, I think, better.
I couldn't get the question very well. What is the question again?
So the question is, right now, as a physician, we bear the burden of conveying the progress and convincing the parents to permit us to carry out the treatment options when the parents are already in an unpeaceful state of mind, as well as the physicians are also in an unpeaceful state of mind. How to go about this situation when both are unstable?
But already people are very acquainted nowadays. The problem of this pandemic is a lot of information and the conflicting information as well. So already everybody is asking, and everybody is asking for help. I think there is no need to convince people. Everybody is seeking help from the health professional. And I think their anxiety might them. I receive maybe 40, 50 telephone call a day asking for things from the parents. So I think there is no need to convince them. They are already convinced and they are in a panic and they need any help from the health professional. I don't know if I answered the question or not.
Yeah, because of the lack of time, this is going to be the last question, and it is for Dr. Jhansi. Dr. Jhansi, you mentioned about nebulization of interferon in one of the treatment slides. However, is the nebulization advised to COVID patient? Should it be given in any other route? Update says as much as possible to avoid nebulization in COVID. So any form of aerosolization is avoided. But what is your opinion about this interferon? Even Dr. Isawi can throw light on it. Sir, your experience.
Yes, I can answer.
Nebulized interferon, your experience.
Yeah, we limited experience actually. We have it's only one study from Hong Kong who highlighted the use of interferon 1 beta, and we use it. The last update of Ministry of Health added it based on this Hong Kong study, and we have two ways to use it as a subcutaneous or inhalation, 8 million Q8 hour for 5 to 6 days. And the other option is to give it subcutaneous. And I don't remember the dose because I don't use it. Why? Because first line management of patient before even come positive suspected is to give anticoagulation. So if you give subcutaneous to a patient who is anticoagulated, you will have subcutaneous hematoma and the drug might not be absorbed. So inhalation is my preferred way to give it to the patient 8 million Q8 hour for 6 days. As I remember, subcutaneous is another option, but how can you do it? And one of the fundamental line of management is anticoagulation. This is
actually this nebulization is more effective in pediatric patients. It is rarely used in a critical ill child. But when you are giving a nebulization, better give nebulization through a spacer to avoid this aerosol generated procedures. Right. And moreover, we are dealing with these patients in an isolated negative pressure rooms. So when it is indicated, it has to be given by inhalation only. There is no other route. And you have to be very careful while giving that nebulization. Better use a spacer.
Right. That is what even Dr. Isawi told. Okay. Now with this, we came to the end of today's session of series of webinars on COVID-19. Hope all of you enjoyed the talks. I profusely thank our esteemed speakers for their very informative lectures. I also keep on record my sincere appreciation for the President and the Dean for their unconditional support for academics. A big thank you to the co-organizers, Dr. Chaitanya and Dr. BG. Actually, today is Dr. Chaitanya's birthday also. You can wish him personally. And our team headed by Mr. Nasir. Also, a big thank you to all the attendees for your active participation. We'll be back again on 16th of August, same time for another informative session on COVID-19. Thank you all. Stay safe and stay healthy. Thank you very much.
Thank you.
Thank you.